Hello and welcome back everyone. So continuing our discussion about the airway management, and after we talked about the bedside assessment of the airway, now we are going to talk about the modalities of airway management. And we learned that the patients with the Glasgow Coma scale of 8 or less may have lost the pharyngeal muscle tone, and they may also have lost the cough reflex and the swallow reflex. And this means that these patients with a Glasgow Coma scale of 8 or less can't protect their airway, so they need airway management. And we have several different modalities of airway management. And those are divided into the basic airway management and the advanced airway management. So in the basic airway, we have maneuvers such as the head tilt, chin lift, and the jaw thrust, and we also have the airway adjuncts such as the Oropharyngeal airway and the Nasopharyngeal airway. And then in the advanced airway, we have the extraglottic devices and the endotracheal tubes. And then we have the surgical airways such as the cricothyrotomy and the tracheostomy. And in this video, we will focus on explaining the basic airway management, and then we will explain the advanced airway in the videos to come. So let's start with the maneuvers. So the first maneuver we have is the head tilt chin lift. And this is the most basic maneuver that can be done. It's very simple and it can be done by anyone. So it is achieved by tilting the head back while keeping the mouth closed. So the teeth approximated, and by tilting the head back, this would put the patient in the sniffing position. So head tilt means that we push on the forehead in this direction, and chin lift means we push on the jaw in this way. So we get this here. Now tilting the head, which is extension of the head, lead to posterior oropharynx gets further away from the base of the tongue and opens the airway. So by extension of the head, which is tilting of the head, the posterior oropharynx here gets away from the tongue, leading to opening of the airway. Now chin lift, on the other hand, will lift the mandible which attached to the tongue. So the mandible is attached to the tongue. So when it is lifted, this means the tongue will be lifted too. So by lifting the chin here, the tongue is attached to the mandible here, and it would be also lifted, means opening the airway. Now head tilt chin lift is used in non-trauma patients, which are patients with no suspected C-spine injury, because this maneuver would manipulate the C-spine into injuring the spinal cord. So the jaw thrust, which is another maneuver, is done instead in trauma patients suspected for C-spine injury. Now to perform the jaw thrust in trauma patients, two emergency providers have to be involved. One to perform the jaw thrust, and the other one is to stabilize the head and neck area to prevent manipulation and injury to the spinal cord. So the jaw thrust is done by both hands on the face of the patients. The palms are on the zygomatic bone, and the fingers lifting the jaw and the thumbs opening the mouth, such as you can see in this picture here. So the palms are on the zygomatic bone, the fingers are lifting the jaw, and the thumbs are opening the mouth. And this is here is on pediatric patient. Now let's talk a little bit about the spine motion restriction. Now the spine motion restriction is the maneuver done to stabilize the head and neck area in case of suspected C-spine injury. And the spine motion restriction can be done by applying a rigid cervical collar, which is not enough because the spine has to be furtherly stabilized by using sandbags and several straps on a stretcher to prevent the head from moving. So both the rigid cervical collar and the straps and the sandbags into a stretcher are applied to prevent the head from moving. Now the spine motion restriction can be done manually by an emergency provider by applying hands to both sides of the head into the neck to stabilize the C-spine of the patient. Like you can see in this picture here, so both hands are applied into the head and neck area to prevent movement, and it can be done from the other side. Also, the hands can be applied like that to stabilize the head and neck area. And if the patient on a cervical collar need airway management, then the collar is removed and the head is stabilized manually and the airway management is done, and then the collar is put back again. Now let's talk about the airway adjuncts. So we have two types of airway adjuncts. We have the oropharyngeal airway, the OPA, and the nasopharyngeal airway, which is the NPA. So the oropharyngeal airway is put to bypass the tongue, thus preventing tongue prolapse in unconscious patients. So it will provide airway patency but not a protection, so it is a temporary measure until the definitive airway is made. Now indications of oropharyngeal airway is in coma patients when the patient doesn't have gag reflex, because the oropharyngeal airway is gag stimulating. So it has to be put in coma patients who doesn't have gag reflex. And this is here how the oropharyngeal airway looks like. Now the oropharyngeal airway comes in different sizes and it has to be measured from the first incisors to the angle of the jaw. So it has to be measured from the incisors to the angle of the jaw here. And if the oropharyngeal airway size is less or more than the ideal size of the patient, then it might lead to airway obstruction instead of opening the airway. Because too small oropharyngeal airway might push the tongue into closing the airway. Because it is too small, it's gonna push the tongue backwards and block the airway, and too big might go into the esophagus and block the airway too. So it has to be measured correctly. Now placement is by entering it upside down until it touches the hard palate, then it is flipped and entered to bypass the dome of the tongue. So it is flipped to bypass the dome of the tongue, like you can see in this picture here. So it is inserted upside down until it touches the palate here, then it is flipped upside down and inserted. Now oropharyngeal airway can also be inserted by depressing the tongue by a tongue depressor and inserting the piece. Now regarding the nasopharyngeal airway, so if the patient does have gag reflex, then the oropharyngeal airway is contraindicated and the nasopharyngeal airway can be used instead. And that is because anything introduced nasally is less gag stimulating than orally. Now the nasopharyngeal airway is longer than the oropharyngeal airway for the same patients. This is how the NPA looks like. Now regarding the contraindications to the nasopharyngeal airway, so it is contraindicated in basal skull fractures and patients with these fractures present with symptoms such as otorrhea, raccoon eyes, like you can see in this picture here, and Vatel sign. Now why is it contraindicated? Now it is because the cribriform plate could be fractured in these patients and the nasopharyngeal airway can enter the brain through the cribriform and causes brain injury. Now, the nasopharyngeal airway is also contraindicated in severe midface fractures, and those are commonly associated with basal skull fractures. Now, the nasopharyngeal airway is measured from in front of the nose and should reach the angle of the jaw or the tragus of the ear. So it is measured from in front of the nose and it should reaches the angle of the jaw or the tragus of the ear. And the nasopharyngeal airway is used with water-soluble lubricant to prevent injury to the mucosa of the nose and then introduced into the nose. And the device is inserted until the flared end rests against the nostril, like you can see in this picture here. Now, always remember that the airway maneuvers and adjuncts are just a bridge to the creation of a definitive airway. And if both adjuncts are contraindicated, then continue to do the maneuvers until the definitive airway can be done. And in pediatric patients, the maneuvers and adjuncts have to be done together to keep the airway open because the tongue size is big. So both of the adjuncts and the maneuvers have to be done to open the airway. While in adults, only the maneuvers or only the adjuncts are enough to open the airway. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and subscribe. And if you want to support us more, you can by joining the channel, paying some money to help me free up some of my time to make these videos. Thank you for watching and peace.